I'm speaking with Peter O'Mara, who has written an article for Rural and Remote Health called Frontier and Remote Paramedicine Practitioner Models. Hello, Peter.
Hello, Melissa.
I wonder if you could first introduce the team that did the research.
Apart from myself, the other two authors on the paper are Gary Wingrove, who works for the Mayo Clinic in the US, Minnesota, and Mike Nolan, who works for the Renfrew County Paramedic Service in Ontario, Canada.
Fantastic. And can you tell us a bit about what your article's about?
It's really an account of how paramedicine has developed over the years, from its volunteer, almost military beginnings right through to the present day when we have a highly technological model that has lots of interventions, and how it's actually starting to develop into more of a practitioner role and having greater primary healthcare responsibilities, particularly in high-income countries where the population who call ambulances tend to be older, shall we say, and their conditions are not necessarily the traditional types of calls that you'd think an ambulance would get with trauma and heart attacks and things, which we still get, but we're increasingly getting the diseases of older age and more complex conditions, and a bit more like what GPs see. So we're talking about, how that's changing the role and trying to get seen as a profession, because often when people do health planning in rural areas, they'll often talk about the patient presenting in the emergency department, for instance, and forget that actually a clinician's already seen this patient, often many hours before anyone else. And we're often neglected in plans for primary health care, how to improve primary health care in a rural or remote area, when there may be no doctors, few nurses, probably no or very few allied health, but there's nearly always going to be a paramedic service there with people who've actually got the training and expertise and got some time, and they're just not used because we're really forgotten or invisible.
It's very interesting. Are there many differences? I noticed this paper's in the North American region, but you're in Victoria, Australia. Are there differences between the two countries?
Fundamentally, we have the same paramedic system, which is staffed by paramedics, and so that's what's called the Anglo-American system. So we share this with North America, the UK, ourselves and a few other countries like New Zealand. There are, however, some quite big differences between the countries, despite the similarities. Probably the main one that's obvious now is the educational standards. Paramedics in Australia, New Zealand and the UK are more or less all trained in universities and do 3 and 4 year degrees as the norm, whereas in North America that's still developing. So Canada's getting quite close. They've got quite an extensive plan to introduce university education in the next few years. The other difference is that, partly because of our educational differences, but also our history, is that paramedics in the UK, Australia and New Zealand tend to operate as more autonomous practitioners, whereas in the US in particular, paramedics work under the licence of a medical director.
Oh, so quite different.
It is.
Yeah. And what steps need to be taken, Peter, policy-wise or education-wise, to make this practitioner role more recognised?
Well, I think the scopes of practice for paramedics needs to be much clearer, and I know in the US they're working on that project at the moment. So that needs to change. There needs to be consideration given to prescribing rights, and that's already happening in the UK. And there's been legislation passed in Victoria, anyway, in Australia, to maybe facilitate that. So that's a big change. As I said, we need a change in education. So people actually have the education necessary to undertake the sorts of roles that medical directors are taking in the US. if you don't have the underlying education, you really can't provide the leadership that's required in the medical area. We need to look at self-regulation. That's happening was happening a long time ago in England. It's happening in Australia and New Zealand. It's happening in parts of Canada. It hasn't really happened in America because of the role of medical directors, or I guess the critics would call it medical domination. The other thing that needs to be resolved, and we're going to face this problem in Australia, is how do we resolve still having lots of volunteers and first responders, and where do they fit into the system? Who provides guidance and support for them? Because they'll still be doing a pretty traditional sort of role. And the other big issue, particularly in the United States, is reimbursement. At the moment, ambulance services have traditionally, they've been paid for transporting people to hospital. If you don't transport, you don't get paid. And that's really causing problems for the rest of the health system. Because the last thing a busy hospital wants is a whole lot of people who don't need their care turning up on their doorstep of the emergency department and clogging up the system. And, you know, people are in the wrong place at the wrong time, and it just makes no sense. But the reimbursement systems encourage ambulance services to take patients to the emergency department, and that needs to change.
Yeah. And what kind of a role, how can paramedicine educators work alongside other rural health educators or rural medicine educators to, align these two?
I think the big challenge is for us to engage more with the other professions, whether it's in the universities or out in the field or at conferences and things like that, and getting published in journals and saying that we exist. We've been the problem because we haven't actually been very good at promoting ourselves. We've had some role confusion, I suppose you call it, where we've often been born of the emergency management system, responding to disasters and motor car accidents. So many paramedics see themselves as aligned to the fire brigade and the police rather than the health service. So, making that jump to say, look, we're health professionals. We train in medical schools and nursing schools and general health schools. We don't train in police academies in general. It does happen in other countries, I might say. But, generally speaking, we train with other health professions, and we need to see ourselves in that way. So there's a bit of a leap that paramedics need to take, and ambulance services also need to take the leap of saying, look, these patients who aren't the so-called emergency patients are actually our business, and they're not someone else's business. If someone rings because they're concerned about some seemingly minor part of their health status, it's not good enough to just say, look, we're not interested in you, go away. It's actually, how can we help you? And I certainly know that one ambulance service in Australia, the Ambulance Tasmania, have made a policy decision to actually say, we will accept calls from anyone. We won't necessarily send an ambulance, but we will not tell people to go away. And what they're doing is really becoming more patient-centred. And that's a really important step forward, to say it's the patient who drives the system, not the system driving the patients. Because we found all over certainly the high-income world, that people have tried this approach of pushing people away to reduce demand, and it hasn't worked particularly well. You actually have to give patients options, and that's where these practitioner models are important, because whether the person's in a communications centre helping direct people from that point, or going to their home, their workplace or wherever and seeing them and saying, look, you really don't need to go to hospital. One, I could treat you here, and that's done. Two, we could refer you to someone else, whether it's a GP or a nurse or a physio, or maybe we'll come and see you tomorrow, see if you're still okay. It's not about taking work off other people, it's actually about directing them to the right place, because it's not a very pleasant experience for anyone to get dragged out of home sent to an ED where they don't want to see you, they can't help you, and all you end up doing is becoming very uncomfortable and hungry and neglected. And, it's a silly approach, really, but because of the way we've set up ambulance services, that's been encouraged. And we need to change that by having more paramedic practitioners who can actually make better informed clinical decisions that actually fit in with the health system. So it's about teamwork with other health professionals. And that's just really what the article's about.
Well, it's really fascinating, Peter, and congratulations on the publication of your article, and I hope to speak with you again.
Okay, thank you.